Hi, my name is Manali Kamdar. I'm an associate professor at the University of Colorado Cancer Center. On behalf of my co-authors, I've had the pleasure to present the subgroup analyses for the study TRANSCEND NHL 001, the MCL cohort, that investigated lisocabtagene maraleucel in patients with relapsed refractory mantle cell lymphoma. In the primary analysis of the MCL cohort from the phase 1 TRANSCEND NHL 001 study, Liso-Cel treatment resulted in durable complete responses at 72% with a very low incidence of severe cytokine release, CRS 1%, and neurological toxicity at 9% in patients with heavily pretreated relapsed refractory mantle cell lymphoma. So herein, we report a post hoc subgroup analysis by number of prior lines of systemic therapy and by response to prior Bruton tyrosine kinase inhibitors, hereon going to be abbreviated as BTK inhibition or inhibitors in patients with relapsed refractory mantle cell lymphoma. So just to give our audience a brief overview of the study design of the MCL cohort, patients with relapsed refractory PET-positive mantle cell lymphoma, ages 18 or over, with a confirmed tissue diagnosis, with 2 or more prior lines of treatment, including a BTK inhibitor, alkylating agent, and a CD20 targeted agent, with a good performance status, were eligible for this study. It's very important to highlight that secondary CNS lymphoma, active or in the past, prior autologous transplant or allogeneic transplants were all permissible to be enrolled on this study. So after screening and leukapheresis, patients with a PET-positive disease went on to receive lymphodepletion at standard flu and Cy doses, followed by Liso-Cel infusion. The dose level 1 was administered to 6 patients at 50 million CAR T cells and dose level 2 to 82 patients at 100 million CAR T cells. On study follow-up has been 24 months. The primary endpoints have been safety and overall response rate by an independent review committee. With regards to demographics and disease characteristics, the overall population, a total of 88, and when you divvy them up by number of prior lines of systemic therapy, they were divided into 3 groups, 2, 3 to 4, and 5 to 11. There were 26 patients in the subgroup of patients who had received more than 5 to up to 11 lines of treatment. When it came to dividing these in terms of responses to prior Bruton tyrosine kinase inhibitors, refractory patients to BTK inhibition were 47, and the remainder, that's 36, were not refractory to any BTK inhibition. With regards to refractoriness to the prior BTK inhibition, more than about 65 patients had prior ibrutinib, 29 patients had prior acalabrutinib, 6 patients had prior pirtobrutinib, and 2 patients had prior zanubrutinib. So in terms of the efficacy analysis set by subgroup, when it came to overall response rates and complete response rates, when you look at the entire cohort, the overall response rates was 83% with a complete response rate of 72%. When you look at it in terms of splitting with regards to prior lines of treatment, they were actually quite similar in patients who had received 2 or 3 to 4 prior lines of treatment. However, in patients who had received 5 to 11 prior lines of treatment, the overall response rate was 81% with a complete response that was less than the complete response of other cohorts at 65%. With regards to responses based on prior response to prior BTK inhibition, the patients who were not refractory had an overall response rate of 91% with a CR rate of 80%. And in patients who were refractory, which was about 45 patients, the overall response rate was 76% with a CR rate that was slightly lower at 64%. Now let's talk about the efficacy analysis set based on median duration of remission, progression-free survival, as well as overall survival. So when you look at the entire cohort that has been previously reported, median duration of remission was 15.7 months, median progression-free survival at 15.3 months, and median overall survival at 18 months. So when you divvy them up based on number of prior lines of systemic therapy, patients who had 2 or 3 to 4 prior lines of treatment had a very comparable median DOR, progression-free survival, as well as overall survival. But in patients who had 5 or more prior lines of treatment, the median duration of remission was actually lower at 6.7 months, median PFS at 7.4 months, and median overall survival at 13.5 months. When we looked at them based on response to prior BTK inhibition, in patients who were refractory, the median duration of remission was 5.3 months, the median PFS at 6 months, and a median overall survival at 11 months. In terms of the most common grade 3 or higher treatment emergent adverse events by subgroups, they were generally consistent with the overall population across subgroups, but with a numerically higher incidence of cytopenias in patients who had received 5 or more prior lines of treatment. In terms of AEs of special interest, in terms of the unique toxicities of CAR T-cell therapy, namely cytokine release syndrome or neurological events, they were also similar across subgroups, similar to the overall population. That included patients with 5 or more prior lines of treatment, as well as patients who were prior refractory to prior BTK inhibition. It is very important to highlight there were no grade 5 CRS or neurological events that were reported. With regards to kinetics by subgroup, Liso-Cel exhibited expansion and peak transgene levels consistent with the overall population across most subgroups, but with a numerically lower median Cmax as well as AUC in patients who had 5 or more prior lines of treatment, as well as in those patients who were refractory to prior BTK inhibition. So the better efficacy outcomes, as well as the excellent safety profile that was observed in patients with relapsed refractory mantle cell lymphoma who received 5 or more, less than 5 prior lines of treatment, and those with disease not refractory to prior BTK inhibition support the use of Liso-Cel in earlier lines of treatment. With that, we would like to thank the patients, caregivers, investigators, and study personnel, as well as the fact that the study was funded by Juno Therapeutics. Thank you so much.